Yes, welcome everybody to one of the more final sessions, I think, yes, of this London Valves. But that's not the reason that this session would not be even one of the more interesting ones. So this is about really optimizing TAVI outcomes in bicuspid aortic stenosis. That's one thing. So I hope you learned something about how to treat bicuspid, and then especially on the focus on this session will be the VitaFlow valve from MicroPort CardioFlow. So let me show you the session objectives. So it is indeed to learn the latest developments and understandings and insights on the transcatheter treatment of bicuspid aortic stenosis, to discuss procedural steps needed to treat bicuspid AS with self-expanding devices, and then to go really on a detailed description of the advantages of the VitaFlow system, especially for bicuspids as well, and also on the implantation technique of this device, where all of us in the panel has some experience with. So with that, with no further ado, I'm going to invite Mao first, Mao Chen, yes, to give us some understanding of which data we have on this platform. Yes, those are the latest trial results. I don't know who controls the slides. Maybe you're over here. Yes, so the latest trial results and experience in bicuspid patients. And I think you have plenty of experience. And first of all, in China, you have a lot of bicuspids. And of course, this is a valve coming from your home country. Yes.
Okay. Thank you very much. It's my great honor to introduce the latest trial results and experience in bicuspid aortic stenosis. As my disclosure, I will divide into two parts. The first is anatomic challenges of TAVI in bicuspid patients. As we know, the bicuspid aortic stenosis have different anatomy challenges compared to the tricuspid patients. For example, just be type 0, just 2 cusps, and type 1 have spatial raphy, and the calcification was a little bit higher and heavy than the tricuspid patients, and the dense, and also the calcification sometimes can extend into the left ventricular outflow, always combined with the dilatation of the ascending aorta or tapacity, and the annulus of the bicuspid patients the annulus was not elliptical. This situation can result in the challenges of the occurring of the stent graft, and also have the higher risk of the pulmonary linkage. We know the flow field is some different between the bicuspid aortic stenosis compared to the tricuspid aortic stenosis. The more aortic flow of the bicuspid patients compared to the relatively laminar flow in tricuspid patients. And almost 40% of patients of bicuspid patients combined with the dilated ascending aorta, and some patients with horizontal aorta. This situation is more frequent in China. The first things we do start is just want to find the real maximal compression level. We use a spatial stent, the notus. We know the notus shape is the standard shape. It's kind of, we can detect the compression rate in the individual level. We identified the real maximal compression level looks above the annulus about 6 to 8 millimeters. That means this is a kind of shape of the bicuspid like the volcano shape, not the cylinder shape. This kind of spatial anatomic characteristics can result in the high risk of the immediate deployment of the TAVI device in bicuspid stenosis patients. For example, the possible migration of the biobrossis stent is person diving a little bit into the left ventricle, just because the heavy calcification around in the annula and some other structures laboring to the annula. So if you do more aggressive dilatation, can result in a little bit high risk of the annulus rupture. And also we know the calcification was more common in bicuspid aortic stenosis. This kind of protrude calcification can result in the malformation of the bioprosthesis stent. For example, the underexpansion of the graft and sometimes infolding of the stent. So we can learn from the ATS registry should ask if the patients, bicuspid patients with calcified raphe and the excess definite calcium can result in the high risk of the patients. For example, not only the 3 times increasing incremental of the mortality, but also the high risk of the moderate and above PVL. How about the net trial results? Just because we know so far we don't have the RCT studies, just focus on the bicuspid patients, but we have a few results from the small sample and the observational study. Here should use the bionucleus led by Didier and Deshe should as the demonstrate a favorable bioprosthetic wall performance and good clinical outcomes after TAVI with the Evolut platform in bicuspid patients. But we know the just because almost these patients come from Europe, and so we can find more patients are type 1 bicuspid patients. Else should you propensity matched analysis compare the TAVI in bicuspid patients to TAVI in tricuspid patients, and you can find almost the endpoints, including days, disabling stroke, hospitalization, valve thrombosis, and conversion to surgery are similar between the tricuspid patients and the bicuspid patients. Our center do a long-term 1-year follow-up focus on the different morphology of the bicuspid patients. We found if we compare to the type 0 bicuspid and type 1 bicuspid and tricuspid aortic stenosis, we can find the endpoint, the clinic endpoint almost the similar, but the type 0 bicuspid combined with the a little bit higher residual gradient, but less new permanent pacemaker implantation, and the dilatation of the ascending aorta different cut-off points to influence the final result. We can find type 0 bicuspid patients over the cut-off points 42 millimeter, but type 1 bicuspid patients 45 millimeter. And the just because our data was from the self-expanding device, and how about the balloon expandable device from the ATS registry? Marker showed the bicuspid patients have the similar results. Almost the clinic endpoint compared to the tricuspid patients, but bicuspid patients have the higher risk of stroke and the lower pacemaker implantation. The meta-analysis just focus on to compare the balloon implanted device and the self-expanding device in bicuspid aortic stenosis. Should the while the balloon implantable device had narrow rates of second valve implantation and the pacemaker implantation rate, but the annular rupture was much higher for balloon implanted device in treatment of the bicuspid aortic stenosis. And the meta-analysis just including the propensity matched studies, 4 studies focus on the compare the TAVI versus the SAVA in bicuspid aortic stenosis. In selected patients of this bicuspid stenosis, TAVI was associated with similar in hospital mortality of stroke compared to the SAVA procedure. So we know not this, we have so many clear information to the TAVI in bicuspid patients. For example, how to select the right patients to reserve the TAVI procedure is safe, and also how to tolerate procedure planning. But we must understand not this we have insufficient evidence to support the TAVI procedure in bicuspid stenosis. For example, we don't have the randomized controlled clinical studies focused on to compare the TAVI versus the SAVI. Also, we don't have the very solid evidence to support the TAVI results in different morphology of the bicuspid stenosis. But the other things, moreover, we don't have the enough data to focus on the long-term follow-up because we have some concern about the long-term durability and the follow-up results. So I'm just stop here. I wish you have some question to ask and interaction. Thank you.
Well, Mao, yes, indeed, you gave us already a little bit an overview of the evidence available of TAVI and bicuspid, but in the meantime, I've been writing a couple of things down on this smart screen, and maybe you can give us an answer or tell us, is there evidence? What's your opinion on this? If I think of TAVI and bicuspid and evidence available, first, not talking about the valve, you already see there's a lot of aortic pathology also associated with these patients. Do we have any evidence or any data showing what happens if we treat patients with some kind of dilated aorta after TAVI? Does this stay in the majority stable? Is there some progression? Do we have data at all on this? Can you share on that?
Yeah, we have the follow-up in our center. We just found about 1/3. That means maybe the one-third patients just stable, one-third smaller, and one-third larger.
Progression.
Yeah. So I think that's because the mechanism of the autopsy, not only from the hemodynamic abnormalities of bicuspid stenosis, but also some patients just related to the genotype abnormalities. This is why I think the different patients have the different performance of the dilatation of the ascending aorta.
So genotyping is important in that you say 1/3 stays stable, 1/3 even gets a little bit smaller, 1/3 there's some further progression. I think we also have some data on that with CT follow-up up to 4, 3.5, 5 years. Actually, what we found there was 85, and this is TAVI in dilated bicuspid with dilated aorta. 85% of aortas seemed to be stable. There was 15% of cases with progression, and that seemed to be related with some kind of procedural results. I mean, on how good the expansion of the procedure was. If there was a long calcified trachea and the valve was tilted, there was more wall shear stress. So there also optimizing your procedural outcomes are probably important to keep that stability of your aorta. I think we still have, I think you agree, we miss really a lot of long-term data. I mean, we do all TAVI and bicuspid, but there is hardly any data beyond 2 or 3 years of how the durability of these valves are and how the hemodynamics and also PVL rates, because there is more PVL after TAVI and bicuspid. So I think we're still missing a lot of data. Yes, that's obvious. But I think, yeah, so we don't have the answer on this. But I think in this session, we want to go further in optimizing the procedural outcomes at least, some tips and tricks, and also how the VitaFlow could fit into this. So indeed, we go, yes, to the next. If Matthias already arrived, I don't know.
Yeah.
Yes? Okay, good. Matthias, so you're the next speaker with your tips and tricks on treating bicuspid aortic stenosis with self-expanding valves. So please share your experience on this and your tips and tricks on how to optimize your procedural outcomes at least, yes?
Okay, thank you. It's an honor for me to be here. I will try to explain what we did or what we do with this valve and bicuspid aortic valves. These are my conflicts. And bicuspid aortic anatomy is as complex as this slide. So to summarize, there are, when we use self-expandable valves, there are non-circular or inadequate expansion of the valve. So this may lead to impaired valve durability. Also, there are some cases with incomplete apposition, and that leads to more gradients or impaired hemodynamics. So we need to make aggressive post-dilation, and this may cause annular rupture, major risk of annular rupture. Also, because it's difficult to deploy the valve in some anatomies with angulation, there are some cases in bicuspid aortic valve that we have migration, ventricular or aortic migration, and that leads to paravalvular leaks. So there are also more rates of valve in this type of anatomy. So also bicuspid aortic valve is associated with aortopathy or horizontal aorta. So there is a very challenging anatomies where it's very difficult to go through the aortic arch and also to pass through the bicuspid aortic valve. So there are some risk of rupture of the annulus and also damage of the aortic ascending aorta. In terms of sizing, there are different methods of sizing, but we use almost three. The annular sizing, supraannular sizing. In some selected cases, we also use balloon sizing, but not in all cases. What B-volute registry has shown that there are not different in outcomes if we use supraannular measurements or intraannular measurements. So we have to put an eye, depends on the anatomy of the bicuspid aortic valve. However, supraannular assessment is in some patients critical because we can see how elliptical is the annulus. We can see the raphe, if the raphe is too much calcified. We can predict if the calcification can be pushed by the prosthesis that we are going to use. And also we can see where is the sealing site, where we have to put the valve to optimize this sealing feature. So in terms of anatomy and where use supraannular or not supraannular, it depends of the anatomy of the bicuspid. In patients that there are a tapered anatomy, there are discordance between the annulus sizing and the supraannular sizing. You can see in this example, if we base the selection of the device on the annulus sizing, we are going to oversize the device. So it's reasonable in this tapered anatomy to undersize the device. In the other hand, if we have cylinder anatomy, there are a correlance between the annulus sizing and the supraannular measure. So we have to take this in mind once we measure. Also, we use the sizing to select the predilatation. This is important because 100% of patients in bicuspid aortic valve, we need to predilate. So we use, in this case, the supraannular measurements to try to see the minor diameter of the annulus and try to add 2 or 3 millimeters, and we select balloons that is according of this measure. In this case, the minor diameter is 15, so we add 2 or 3 millimeters, and we choose a 18 millimeters balloon to predilate. And this is safe in terms of risk of annular rupture, but also is effective to generate a big room to then do a safe procedures. In terms of positions, the valves all know that high position is best in bicuspid, but the question is why? Because we are trying to put the valve as high as possible, because in the inner flow of the part, in the valve, in the inner flow, we have more radial strength. In this valve particularly, the high density cells is in the inflow. So if we use this landing zone, we are going to use all the radial force in the zone of the calcification. And also we are going to use the sealing skirt that is in the inflow. So we try to go at 0 or 2 millimeters. In terms of tips for high implantation, what we use usually in bicuspid, we try to put the valve in cast overlap or light cast overlap, because there are not 3 casts, but usually we use this right caudal projection, and we aim to 0 position because this valve will not move, will not advance, so we not use a top deployment and then advance the valve. This is very stable device, so we don't need to put up or put down. And when we are happy with the position, we usually push the deployed button, and under pacing is very stable and very easy. We always do under rapid pacing or mid pacing in bicuspid valves. So when we are happy with the position, we check in 2 different views, CAS overlap and LAO projection. And if we are happy, we are okay with the position, we release the tension on the wire. This is important to try to do not push the valve in the aorta. We release some tension of the wire, and then I suggest some pacing during the final release to try to avoid movements, and we press the release button. And this is one of our results in heavily calcified bicuspids. Another important point and tip in bicuspid valve is try to detect underexpansion of the valve in the procedure, not before the procedure. And in this case, as you can see, there are some discordance between the CAS overlap view and the left view, and this is because the valve is not well expanded. So if we detect this, please post-delay, because we have data that underexpansion valves in long terms are not good outcomes. So this is another important point. And the last point is trying to be safe when we go through the aorta with the valve, because in bicuspid anatomy we have a dilated aorta. So what we do usually is try to use a stiffer wire. In this case, Landerquist wire. There are described some technicals with snare. In our experience, we do not use snare. It's not necessary if we escalate with a wire with stiffer support. So my message is supraannular assessment rely on the operator experience. Sizing in TAVI in bicuspid aortic valve combine annular and supraannular, and is in some cases reasonable to downsize. High position of the implantation could increase effectiveness of the THV and detect underexpansion of the device and post-delete if needed. And stiffer wire would be useful in challenging anatomies. Thank you very much.
Thank you, Matthias. Thank you for sharing your experience, which is huge with this device. Also, it's particularly interesting in bicuspid because we in Europe have 7–8% of our patients, but in your population, as in Asia, the proportion of bicuspid is very high. So if we can show the blackboard, please. When you are facing a bicuspid patient, from a practical point of view with this device, which is quite cylindrical, you have a patient where you measure an annulus, and then you measure the intercommissural distance, and there is a mismatch, 25–23. Which is your mental process? I mean, you base everything on the annular measurement. What do you measure supraannular? How high you measure? How you consider the RAFE, calcification, length, and do you use balloon sizing? What do you do? What do you do?
Okay,
mental process.
Yeah, it's a mix of all of this. Because bicuspid anatomy is so complex, it's so homogenic, you have to use a mix of these techniques. So we look everything. We look annular, we look supraannular, we look the RAFE, the calcification, and we try to integrate these images to decide the size of the prosthesis. In case that we are not sure, we have the third technique, that is balloon sizing, that sometimes is useful, not for all patients, because you need to be prepared with the valve, and you need to know how the size of the valve. But in summary, we integrate all the images, but if the patient has tapered anatomy, we rely too much in the supraannular measurement.
So this is a high radial force valve, At the time of ballooning, do you balloon aggressively or mostly with a small balloon just to make sure the crossing is going to not to be an issue? Or sometimes, if you really have an adverse anatomy, you prefer to balloon with a large balloon, more adapted to the ICD?
It depends on the anatomy. If there are a big chunk of calcium in the LVOT, we try to be conservative. If there are not, we try to predilate in some way safely, but big enough to have to avoid post-dilatation. But yeah, depends on the patient. But we predilate all patients.
Probably the main conditionant of the prognostics is the RAFE, right? This length, if it's more than 50%, as our colleagues from Italy has described, or very calcified is the main conditionant that might lead to undersize a little bit the device as compared to based only on annular sizing. But what do you think? Any questions from the audience? Shall we move, Ole? Or?
Well, Ignacio, I want to share still something on how I look to then, if we go in detail on the VitaFlow specifically, before we go then move on clinical data and the case. How do I look to this platform? You saw it already now in some images from Matthias. We will show it more. But how do I look to this valve? Look, to me, I like compromises in my life. I think I'm famous for that. And I think this is a great compromise valve in a way from the design. The design is great. It's great for bicuspid. So I'll share my vision on this, and then we can discuss this openly. But you can have either a valve which has, I'll draw it something like this. Either it's a specific valve or a virtual valve. I'll leave that in the middle, but again, in the middle. But or you have a valve, something more like this, with a very dense network. Some of you will recognize some valve in that, but okay, that's fair enough. So what I do like about, so this is one particular valve, another particular valve, self-expanding valve, and then I will try to do that in a good way. That's maybe too much already. It's a little bit less tapered, something like this maybe. And then here, nice open kind of, yeah. So here it's also pretty dense network. And here it's actually very open network. So why do I like this? This is then for me the VitaFlow in the middle. So why do I call it some kind of compromise in the design, or not a compromise, a kind of the perfect golden middle? Because look, what I do not like sometimes on valves is there are a couple of different aspects. First, on the stand frame only, the leaflets are not integrated in that. This is an extremely straight valve, yes, tubular, yes. That can have some advantages, but it can also have disadvantages, because if you implant it very high, this kind of very tubular valve, and you want to aim for a very high implant, sometimes you get a champagne cork effect, the valve kind of embolizes. This other design of valve with a very, really a pronounced waist, especially if you go for the bigger valve sizes, sometimes it's difficult, predictable, where it will move and sometimes dives into the LVOT. So in a way, for the stability with the release, now it's not, my drawing skills are not perfect, but this valve, this VitaFlow valve, has a tiny bit of a kind of a tapering, but it's not completely straight, which I don't like if you want to go for high implants, because you risk pop-ups. It has a tiny bit of a waist, but not a pronounced waist. Yes, so that's one thing which I like. The other thing why it's really good for bicuspids also, but maybe not only for bicuspids, is that you see what they do, and that I think that's smart, that's the way to do it, is we need radial force at this particular region. That's where our calcified leaflets are, or our calcified raphe. We need radial force to push these calcified leaflets and or the raphe on the side. So if you have very open cells, that's all great for coronary access, but we want radial force on the inflow. Yes, if you have too wide open cells, maybe too little radial force, here you get radial force, but you have also these cells shouldn't be completely closed all the way up to the outflow, because then it compromises your coronary access. Yeah, so I think also there they make a kind of a nice in-between design with good radial force on the inflow, but nice open design on the outflow for coronary access. And then the last thing is also there, I think it's a little bit in the middle, that you can have either really intra-annular leaflets, really low, or you can have really high intra-annular leaflets, but this can be also a challenge for your coronary access or for redo TAVI. So if you have your leaflets a little bit also there, a little bit in the middle, it's better for, like also if you have a completely intra-annular leaflet position, you have more risk of halt, leaflet thickening, etc. if you have not a perfect expansion of the valve. So also there you can be in the golden middle from your leaflet position. So I think there's a couple of aspects on this design of the valve which make it great. It's like the golden middle for me because of these aspects. Yes?
I actually have a nice picture, Ole, for you here on the valve, if you want to make some comments on the picture that the guys have shared for us. So we'll just show our slides there, please. So my name is Angela McInerney. I'm an interventional cardiologist from Galway University Hospital, and it's great to be here. It's been a fantastic PCR London valve. So we're going to talk a little bit about the product that Ole has just already gone through, and then a little bit about the kind of longer term clinical data. And just as a starter, who in the audience has implanted VitaFlow or knows much about it? Do you want to put your hands up? A few actually, it's just good. Yeah. There are my disclosures. So as Ole has already said, this is a sort of hybrid type valve design where you can see that there's a change in density of the cells from the outflow to the inflow, and you have low density cells in the outflow, which makes the valve very flexible, Ole, at that point, doesn't it? Mm-hmm. And then higher density as you go down towards where the valve needs to seal, and this gives it much stronger radial force at the sealing aspect of the valve, or at the inflow of the valve. And while the large cells preserve coronary access, this is obviously a self-expanding valve which is completely recapturable. And the other sort of unique thing about this valve is its delivery system, which has a motorized deployment of the valve, which actually is a very stable way of deploying the valve. And we'll see in Ole's case later on exactly how it works. But you can deploy and recapture the valve, which is completely motorized. And I think Ignacio has actually just recently done a live case using this valve where he did it entirely as a single operator. And it's a very smooth deployment of the valve, and of course recapture if you need to reposition. So we've already kind of talked a little bit about bicuspid valves and the challenges that they present. And this, we're going to talk a little bit more, I suppose, about how this particular valve might actually solve some of the challenges that we face on a daily basis when we're trying to perform TAVI in bicuspid valves. So we've already spoken about the fact that these have a number of challenges, including the aortopathy that comes with many bicuspid valves, but also that they have very dense calcification. And the calcium does actually tend to be a little bit higher, although it can be annular calcium as well, and also extend into the LVOT. And then, of course, the annulus that you're trying to size is often quite elliptical, and we're not really sure which is the best sizing method for these. And all of these issues, of course, affect things like the anchoring stability, how we size the valve, what the valve is going to look like after being deployed, whether it's going to be infolded, etc., and whether or not we end up with paravalvular leak. So the VitaFlow system is a unique system in its design, and actually some of its design features can help to solve these issues with us. So as Ole already said, that this is a very tubular valve, and it doesn't have a tapered or a wasting of the valve, and that can be very tiny bit, yeah. And that can be helpful because it's a lot more predictable in terms of the formation that it's going to take inside your annulus. And it also, when you're trying to size for your bicuspid valve, you know that you're going to get when you implant this valve, you know that you're going to get a very circular and uniform implant of the valve. Secondly, we've already discussed about the different cell density, and with this, a greater cell density at the base of the valve, or the inflow of the valve, which gives it its radial force. And this valve has very strong radial force, which helps it to seal, of course, at the annulus, but also, as we've already heard from Matthias, maybe allows you to implant it a little bit higher so that you can also get some sealing a little bit higher as well, which is often where we have the calcium in bicuspid valves. Additionally, as we already spoke about, is that if you do need to post-dilate this valve, it's a lot more predictable because of its tubular shape and because it expands in a very uniform direction. So predicting your final result with a bicuspid using the VitaFlow is a lot easier. And as I just already said, you can alter the implantation depth because you do have radial force at the annular level, but you also have a skirt, and the radial force allows you to get good sealing at the annulus, and therefore you can implant a small little bit higher, and then you will also get good sealing all the way up as far as where your height of calcium is with these bicuspid valves and prevent paravalvular leak. And the last thing is, of course, the orifice area or the final transvalvular gradients that your patient is going to end up with. And having a tubular valve as well also is a lot more predictable because the size is a lot more uniform throughout the entire valve frame. So we're going to just quickly look at some of the data that we have on this system, and this is the VITAL trial, which we now have 8-year follow-up data on these patients, and Dr. Chen can speak a lot more about this. But it's important to note, I suppose, that this data stems from the use of the first-generation valve. It also stems from a time when bicuspids were only just being started, really, to be treated with TAVI, and also when we didn't use things like cusp overlap for implantation, etc. etc. This is a study that took place in very large centers across China. And it included a total of 110 patients, and these are the patients, the overall inclusion criteria. So these were high-risk patients. So it's the early days of TAVI. You can see these were 77 years of age. The mean age was 77. The mean STS score was 8.8. What you can also see is that there was a very high proportion of bicuspid valves in this study, much higher than we would get in any other sort of all-comers study, with about 38% of the valves included being bicuspid. And when you look at the characteristics of the bicuspid versus tricuspid patients, as you might expect, the bicuspid patients were a little bit younger and had a slightly lower STS score, but really these were, in general, high-risk patients, and there were no other major differences between these two groups. In terms of the long-term outcome with this valve at 96 months, so at 8 years, the all-cause mortality was 39.1%. This, again, is an elderly, high-risk population. We do expect all-cause mortality to be reasonably high, but once you get out to 8 years post-TAVI. But when you look at when you break down the outcomes for these patients in the bicuspid patients versus the tricuspid patients, you can see that there was reduced all-cause mortality, although not statistically significant, in the bicuspid patients versus the trileaflet patients. And also you can see that there's a trend, although none of them are statistically significant, but there is a trend towards better outcomes in the bicuspid patients in terms of all-cause mortality, but also in terms of lower rates of pacemaker. And of course, most importantly, when you look at the durability of these valves and you look at their long-term outcomes in terms of degeneration and transvalvular gradients, etc., you can see that there was no real difference between the tricuspid and the bicuspid valves. And you can see even out to 8 years, there was a small period of time, which is generally during COVID, where these patients weren't followed, but then they continued to be followed after COVID. But you can see that the effective orifice areas were quite maintained, as were the transvalvular gradients. So just to conclude then, the VitaFlow is a TAVI which offers some features that may be advantageous in bicuspid patients. The VITAL trial indicates that patients who were treated with VitaFlow had good long-term results, and there was no significant differences really between the tricuspid and bicuspid patients. And this is also a safe device, and long-term outcomes in terms of effective orifice area and transvalvular gradients are maintained even out to 8 years. Thank you.
Okay, great. Thank you. Thank you, Angela. It's actually quite impressive to see that there's already data out up to 8 years and in quite good number of patients, actually. So that's you have clearly the most experience with this device also. So what's your take on your valve choice in bicuspids? What do you look for, Mao and colleagues at your center? If you, maybe we have the boxes here. Yeah, you have a box? Or you have a mic? Yeah. So if you go for a valve choice in your in your bicuspid population? What characteristics do you take into account? Is it the valve itself, the results you have on valve? Is it the patient's anatomy? You have a lot of type 0s too. Is it a very different animal than type 1? Can you please share your take on that, because you have so many bicuspids?
Yeah, I think the TAVI in bicuspid patients, I think the different device maybe have the different application. For example, if the patient is very horizontal and very dilated ascending aorta, in this situation, we obviously choose the possibility of the balloon implanted device, just because to avoid the damaging of the ascending aorta. But if we want to choose this safe implanting device, the first thing I think very important, how to define the real maximal compression level, supraannular level. We also think the RAFI and the heavy calcification can result in the real maximal compression level. By this level, we will describe the inside contour of this level and get the supraannular size. If we make sure the supraannular and the annular size, we will choose the, just like you have seen, the different shape of the fibrosis stent can have the different result.
Yep.
If we think it's very taper, in this situation, maybe we're using the very small waist, just because, you know, to me, I always think the real maximal compression level is very difficult to slip out.
Yeah.
And if you aggressive slip out, you can result in some bad complication like the PVL, whatever.
Yeah, sure.
So we will just describe the whole shape of the aortic root, and to make sure which kind of shape of the safety pan device we were using. But to me, I think if we use the VitaFlow, the high implantation is very important.
But you take this valve also for your extremely calcified bicuspids. This is a good choice for you in your practice, if you have extremely severely calcified.
Just depend on. But to me, I think if the extremely high calcification, I don't think any device is
really strong enough.
Is real optimal.
Ignacio.
I think there are some questions from the audience. Dr. Debrahi.
So when we started our journey with VitaFlow in Argentina back almost 3 years ago, we were kind of skeptical about the motorized release. We didn't know if this will add some value in comparison with other valves. And now I personally think that one of the more things that make this really stable, apart from the high radial force, is the motorized release. Because it takes out the tension from the second operator when you try to do it fast and you don't have some pull or push from him. What are your thoughts about this?
Not true. I mean, yeah, I can share from my own experience. I actually also do, like, in the beginning I was maybe also more skeptical, but it adds for precision. Yes, it goes for a very smooth, very precise deployment. Valve seems to be extremely stable. I have the same kind of experience, but let's maybe show that in a recorded case. Yes, so we can continue here with this is a recorded case. I don't know, from a couple of weeks ago, 3-4 weeks ago, I think, in Copenhagen. So it's a 72-year-old male, which I did with my colleague Gintautas Biliauskas. He's here in the audience too. And this is a particular patient, 72-year-old patient, rather classical patient for us. Normal body stature, even a relatively small Dane, I would say. Arterial hypertension, prior stroke, rheumatoid arthritis, 2-time hip prosthesis. So you see the picture is a kind of a multimorbid patient, not a perfect patient for surgery for sure. He has a preserved ejection fraction, really high gradients. Luckily, no pulmonary hypertension yet. Normal ECG, coronaries are okay. Renal function only slightly reduced. And then we have the anatomy, of course. Here you see in a perimeter 83 also in LVOT. Only tiny bit of calcium there, minimum and a maximum of 23, 29, and a perimeter-derived mean of 26.3. Yes, so that fits very nicely in the range of VitaFlow, the largest valve. We have the sinuses, which are nice, wide, SC junction, really wide, I would say, 35, wider than we would think for this anatomy. And then we indeed do all these measurements, supraannular. We also do multifactorial assessment, I would say. Annulus, we look to the amount of calcium. Is there a calcified raphe, yes or no? Intercommissural distance at 4 millimeter, 8 millimeter, maybe some circle methods. We all use these methods. 29 millimeter intercommissural distance, really severely calcified. As you see, it's a type 1 right-left fusion, which is the most common in Europe. For sure, it's around 70–75%. Aortic angulation, not too difficult, relatively classical, 45 degrees. You see the chunks of calcium really severely calcified. Yes, that's absolutely good visible here. And then the coronaries are not really a worry, they're high. Again, these are the views. We take all these 3 views into our lab. We look to the right-left cusp overlap, or I would call it the NCC isolation view, tricuspid view, we typically don't use, and then the LCC isolation view, we also use. So actually we are mostly interested in these 2 extremes, NCC isolation, LCC isolation. And the arch fits with bicuspid. It's such a kind of a little bit coarctatio-like, tiny bit of narrowing, tiny bit more angulated, so we have to be careful, but luckily not too calcified there. Access is okay, pretty straight, only mild calcification. Caliber of the arteries are good. So the plan, transfemoral TAVI, local anesthesia, pure local anesthesia. There's no conscious sedation for us, no anesthesia in the room. There's pre-closure with Procedural, cerebral embolic protection, discussable, but okay, young person. He has had prior stroke. He's young, prior stroke, really calcified valve. So we do what we can to protect him, but we don't know if it protects really a lot. And then pre-dilatation with a 24 millimeter balloon. Which is on the conservative side still, but okay, we have a perimeter-derived mean of 26.3, so I think it's an acceptable size of balloon, and then a VitaFlow Liberty 27 millimeter, okay? So here you see the recording here. So this is, of course, pre-dilatation, I would say bicuspid. We always, regardless of whatever platform, we do a pre-dil. Also for balloon expandable valves, we strongly believe that a pre-dilatation is mandatory. And you will see, this is even, we repeat this, we keep the balloon pretty high, nice high, 80% aortic, 20% only down the annulus. And you see us repeating this balloon pre-dilatation. It's kind of a double tap pre-dil, which we don't do often, or I would say we do often in bicuspid. We believe, or I personally strongly believe, that it makes additional cracks and modifies the calcium. That's what you want to do. You want to modify the calcium, just like in PCI. If you have a very calcified lesion, you will also not just be satisfied with maybe 1 inflation, but maybe double inflation, cutting balloon, whatever you do. So you try to modify that calcium as good as possible. Here you see us demonstrating the VitaFlow system. We check it under the fluoro if the loading was good. That was no problem. And then it's an integrated sheet on this platform. So the 16 French sheet comes out, and then this sheet goes in. And then the tracking is actually pretty nice. It's a quite robust system, I would say, to bring it in, but we have never really had problems tracking it. It's a matter of being gentle with the system and with the anatomy of the patient. So it tracks as normal system as you know, I would say. So here we go up. You see us, there's a pacer in the right ventricle. That's not always we do, but this is a younger patient, bicuspid, especially the fact that it's a bicuspid valve. We know that pacemaker rates are higher there. So here we will we connect for the pressures. We quickly flush here to get the pressure tracings. Maybe we will see that soon. Yeah, here the hemodynamics comes in the picture. The sentinel you see sitting there. Okay. And now we can continue. We'll go to a slide LAO projection. Oh, sorry. Oops, that was not the purpose. Can we get the video on again?
Yeah. I can
maybe,
advance.
yeah, you can advance a little bit. Not that much, I think.
Oh, okay.
Much back, I think. Even let's go here. I think we were somewhere here. Yeah. Okay, maybe we make a small jump further. Yeah. Okay, that will be the tracking of the aorta then soon. Of the aortic, crossing the aortic arch, yes. I'll keep this on the side. And you see the handle is extremely easy. I don't know where the handle is. It's in the audience, I think.
Somewhere over there.
But it's pretty simplistic, yeah. So here you see crossing, you remember this is a little bit angulated arch. We do this with love and tender, I would say. We go really kind of gentle over that arch, not to dissect anything. It goes, tracks really nicely. This is in an LEO view, but now we go, of course, to the NCC isolation, or the right-left cusp overlap view. We make our descent into the valve, and we cross the native aortic valve. Our pigtail is a little bit difficult here. As you can see, it comes probably from radial, I can see. Yeah. And then it is definitely the fact that we go to the cusp overlap, so-called cusp overlap. You see there's a little bit of parallax. Very often, both me and my colleague, we will take out the parallax. So if there's a little bit, you can nicely appreciate that on the ring. If there's some parallax, we typically prefer to take it out. I don't know if we did it here by going a little bit more caudal if we can. I'm not sure if we could. You see the angles, it's REO 10, caudal 38, so it will be difficult to go more caudal. If you can't go more caudal, then you can take a little bit away REO to take that parallax out, but maybe we didn't care too much. We continued here as it seems. It's also minimal. We give some pacing. This is already quite high pacing, I would say. You can do it with a slower rate of pacing, just 120 or so. But I think both me and my colleague, we like sometimes a little bit higher pacing to get the stability. And again, this is the mechanical. So you see there on the hands, if you keep an eye on the hands don't move at all. It's just pushing a knob. Ignacio can tell about that too. He does these cases even as a single operator. We check here, and I think the valve looks really, first of all, it's nicely expanded already. Yes, so the force, the radial force of this device is really, that's really something I'm very happy with. It's reliable. We sit at a good depth. For sure for bicuspid, I would say. Still, we are missing quite a bit. There's quite some gap on the left side. Yes, so it's probably fine. This is an LEO shot. So on the left side, you see we're sitting slightly high. Yes, we're sitting only at 1 millimeter high, knowing that we have to pulse dilate this valve probably in this extremely calcified bicuspid. I think my colleague was tempted to release. I was more tempted to do one additional small just a partial resheet, push it 1 or 2 millimeter lower, and then immediately deploy again. And you see how quick you can do this with this knob, with this mechanical, or not mechanical, with the motorized expansion. Yes, so you can do a recapture and re-expansion extremely fast. Yes, so you don't have to turn there on that wheel. It's just changing, recapture and expand again. I'm more happy with this. We're sitting at around 3-4 millimeter. On the left side, we said for sure, we made sure that we are at 2 millimeter below, and then we do a very slow expansion here. Again, you see on the hands, it's just pushing a knob. There's not much manipulation of the entire catheter, so the valve stays extremely stable with the final release. And I've never really experienced, but that we could. I've never really experienced of final full releases of the valve. It's actually never an issue there that one of the taps are kept on the delivery catheter. It always came off very easy. So here we're already completely released, and we keep definitely the wire inside. You see already, we go straight for pulsal. We don't check for PVL, etc., because you see there was some kind of there was an underexpansion of the valve. Yeah, so we see that as an indication for pulse dilatation, and you see here very nice implant. We sit around 2-3 millimeter. There's actually no leak or only a trace. And you saw also with the final injection. Actually, we decided to even try to, maybe this was 1 millimeter. No, this is the start of the procedure again, so it's a loop. So I want to show you maybe just the last injection again, that you can appreciate that again.
One thing, Ole, is that you really don't need to push the button all the time and release all in a row. So the last release, you can press and stop, so you regulate the speed of release.
Yeah. Yes, so you see here, just I paused it, so you nicely appreciate we're sitting around, I guess, 2-3 millimeter depth. And there's hardly any leak. There was a trace, I think. You see also there's a large anatomy. You see that's kind of small tapering, good expansion of the valve, the more dense nitronal network and the inflow, the more open network at the outflow. So I think for this 72-year-old patient, we got a really good outcome and a very precise implantation of this valve. Yes?
There are some questions for you, Ole, from the audience, from the speakers.
Thank you. No, it's just to remark some topics of this case, particularly you show perfectly. If in this case that the perimeter is 82, if you have to use other platform, probably you are going to oversize and use, in case of Medtronic, 34 Evolut Pro Plus or FX, and the shape of the Evolut is really tapered. So probably was more difficult to put in this position because was going to deep dive in the ventricle. So I think that in this particular case, heavily calcified, big annulus, bicuspid is where this valve has really interest. Because it's straight. You do not oversize. You use the 27 instead of a 30 millimeter valve.
Indeed. So that's an aspect. I hope that was clear to everybody. This was normally, if you would look just to the annulus, you would go for the 31, but we decided indeed, because of all the other measurements and the heavy calcification, to go for the 27. And I think that was the right decision. First, there's no leak. You see a very nice expanded valve. It looks completely expanded. So that's really optimal for the leaflets, for avoiding pinwheeling, for having a good expansion of the valve. Definitely, I think that was the right choice.
I think we have one more comment if we have time. Here you are.
Yes.
Eric Backer, Norway.
Yeah.
I have a quick question for the handling of this specific device. I mean, with other supra-annular platform, at 1/3, you quite often have hemodynamic compromise when you deploy.
Yeah.
I would be a bit concerned with the motorized handling that you could be a bit worried sometimes. What's your experience so far?
Ignacio, well, and yeah, maybe we can go through the big experienced people. And Ignacio, what's your experience on hemodynamic compromise with?
It starts to work very quickly, and also it does not take very long to open up to the valve is functioning. So it's very quick. I normally pace not so quick as with Evolut, like 100 beats per minute, because this stability of the system, so I'm not so scared that the system might pop up. So I go in a row all the way, so we have good hemodynamics really quickly, and only in the last part for the final release, I go more slowly. So normally a hemodynamic release, in my short experience, I have done only a bunch of cases, was quite good.
Maybe Matthias, who has really a lot of experience with us, and also our colleagues here from Chengdu, maybe? Ignacio?
We don't worry in any case about the hemodynamics during the release, because it's stable, it's rapid, so there is not a problem.
No, personally, I also never really experienced there any hemodynamic compromise. You see here, this is of course with pacing. That's why the pressure goes down. That's due to our pacing. But I agree, this is not mandatory. Yes, I mean there is mandatory pacing, but you can do it with 100, 120 pacing. It's just a preference of me and my colleague to do with this expansion. We do it also with other platforms to go there for a couple of seconds to 160. Anyway, I can tell you these patients are in local anesthesia. Yes, they're not conscious sedated, they're not in anesthesia. We never saw any compromise there. What's your take on what do you do for pacing? Your experience of having more experience than us in Europe of hemodynamic compromise during the opening of the valve. Do you see that or not? Or more with this platform than with others?
I think no. I think we seldom encounter hemodynamic collapse during the releasing process, because this valve is actually a long valve, and it can work at the initial release. And also the leaflet is not located too high. Yeah. Yeah, it's between a intravalvular and a very high supraannular valve. So this is one of the advantages. Yeah. And what we encounter most is during the predilatation. Yeah. And after predilatation, sometimes you may encounter hemodynamic collapse especially when you choose a very large valve. So in our center, we usually tend to choose a relatively small balloon for predilatation to avoid any acute aortic regurgitation or rupture of the leaflets.
Okay, good, thank you. I think if any more questions from the audience? Yes? Maybe yeah, you can throw it. Let me throw it to you. Yes.
What are the chances of infolding with this valve?
Okay, good question. I never had one.
Of
but
getting what?
Is there any infolding reported on this valve?
No, honestly, we don't have.
Apparently not. I think that's a very good question. I've also never had it.
Never.
Seems like the valve is really super good at radial force in that way, and yeah, there's high volume sitting here, so never seen it. Yeah. Let's do one more question. We have like 1 more minute, and then we will conclude the session.
What about commissural alignment? Is there any technique, or can we keep it in this way and then rotate it, and then operator should be always facing the top?
That I cannot answer on. I have too little experience on that topic. If it's that, I don't know. Or maybe some engineers can answer on that. I don't know. I can honestly, it's better to say that I don't know it. I think for me, it's too early experience. I should experiment with it. I'm not sure. I think I don't think you can torque the system, rotate it when it's already in the ascending. If anything has to be done there, then it's maybe in some particular view in the descending, and maybe some rotation there before you track across the arch. But I think that's maybe up for
we have to develop the algorithm.
A new research project in the future. So.
But the truth is that the coronary reaccess is quite easy, even if you are not
already. I mean, this outflow is already pretty nice open, so you have quite some maneuverability with the catheter. So with this, I think I have to conclude this session. I hope you learned something about bicuspid, treating bicuspid with TAVI, and also with special focus on this promising new self-expanding valve, the VitaFlow from MicroPort CardioFlow. Thank you.